I've been asked to come and speak about gloves, hand hygiene, the latest initiatives. It's nothing new, quite like the AMR sequence, but it is something that we've done at GOSH, so hopefully it will be a bit of a different picture on how we've done things. So last year we launched a campaign that we called Safer in Our Hands, and it was really to look at the glove usage that we had in the Trust. I'll talk you through some of the reasons why. So we were part of the glove awareness campaign, which the RCN ran. We kind of, I guess, encouraged the RCN that some kind of glove awareness campaign would be useful. And I'll talk you through the reasons why we came to that as we go through the presentation. So I'll talk you through some of the things that we found out at GOSH, our progress so far, and things we hope to do in the future, because we're not finished by any stretch yet. So we felt it was really important to look at gloves. We know this isn't anything new to anybody here. In fact, it's probably one of the simplest things we've done. But we knew that glove usage was really closely linked to hand hygiene. We knew that skin management was really important, and we were seeing people present with dermatitis and contact dermatitis, what looked like, into our occupational health department. We were aware that the RCN National Guidance, the Tools of the Trade, was about to be updated, and thought it was a perfect opportunity to really kind of tie those two things together. And there was something published in the 2016 Standards for Infusion Therapy, which really made us think. So at the time when that guidance was published, I was seconded to the Royal College of Nursing. And there was a sentence in there that really, it didn't surprise me, but it surprised a lot of people, and I would say it's probably the most queried question to the RCN. And it talks about not wearing gloves for the routine administration of antibiotics. So I came back from the RCN, and we discussed this at GOSH. So we'd been talking about this for quite some time. Bear in mind, last year was 2018. We've been talking about it for about 2 years. So our local reasons really are quite simple. So we'd changed the way we did our audits. So we're all aware of the hand hygiene audit programs. I'm sure you all do them in your organisations. We'd tried something different. We tried bringing people together once a quarter and really trying to understand what the issues were about auditing, if 20 observations were useful, and the common reasons why hand hygiene wasn't compliant if it wasn't. And we really tried to encourage all of the link practitioners who came to give us honest answers and collect honest data. And one of the things that commonly came out once we'd re-educated them in how to do hand hygiene audits really was that people were wearing gloves. And when we asked them, they said, well, we just wear gloves instead of doing hand hygiene because then we're protecting our patients. So we realised that we needed to do something about that because the misconceptions around glove use. We knew staff were presenting to occupational health with sore red hands, and we believed that partially some of this was linked to we kept having changes in gloves that came through the supply chain. So at that time, in about 2017, we probably went through about 3 sets of gloves consecutively over about 3 months, where they kept changing and people were presenting. So we wanted to make sure that our management of staff who had any kind of sore red hands was managed correctly so they didn't go on and have dermatitis. As I mentioned around the IV administration, when I came back, I joined some of the practice education team on the skills standardisation days, and we really talked about, do we need to wear gloves? What do we need to wear gloves for? Why are we wearing them? And do we need to wear them for the routine administration for antibiotics? So we've been having these conversations for about 2 years. And actually in the room of about 50 practice educators, practice was really different. So we realised that we wanted to standardise that and make it the same. And then last but not least is environmental impact. So of all the reasons that we did, it was on the bottom of our list, but for our staff, it was at the top of their agenda. I can absolutely say that. All the reasons around infection control, being safer for children, providing safe care, were all acknowledged by staff as being important. But I think if we were to do a survey to say the biggest reason why they adopted the change, it would be environmental impact. So it's just something to bear in mind. It may be our particular staff group, but for us, that was the biggest reason. People really care about the environment and really want to do something about it. As do our children as well, when we were explaining to them about the changes we were making. So these are just a few quotes. I won't dwell on them for long because you all know them. But this is some of the information we gave to staff, and we reminded them. So when we were talking about it, there were 3 of us mainly who kind of started the campaign. So myself in infection control, we had lead practice educators, Nicola Wilson, who worked within the surgical division, who'd done a lot of work around changing the way we did audits with me. And then we had a quality assurance practice educator, Amy Leonard. So we really tried to sort of do it so that it was an infection control driven thing, but actually it was better from a nursing point of view as well. So we would present this to people. We would remind people that the reason that we're wearing non-sterile gloves is to protect ourselves. We wear sterile gloves to protect our patients in theatre and the like. People knew this, but it was helpful to remind them. And you'll see Jenny Wilson quoted throughout, a great advocate of wearing gloves properly. So, and then we reminded them that if we don't change our gloves, it's just as bad as not washing our hands or not decontaminating our hands correctly. And then the last quote, there really is very little data for this in paediatrics. There's very little data for anything in paediatrics, but particularly kind of around PPE use. But we did have feedback to say from families and staff that actually children preferred you not to wear gloves when you were taking care of them. If you put gloves on, they started panicking. They anticipated a medical procedure. I'm sure it's exactly the same in adults. So the changes that we made, we did make more changes, but I've cut them out for this. So the changes that we made were, we really just asked staff to risk assess when they were wearing gloves and aprons, so to make sure that they were wearing them when they anticipated there was contact with blood or bodily fluids. And we did that across the whole organisation. So we spent time with porters, staff on the wards, everything. And then we wanted to promote not using gloves for the routine IV preparation and administration, and we built a risk assessment around this to help staff. So we did it sort of in line with this, or the WHO triangle, if you've seen it, around hand hygiene and glove usage, just as an example. The clicker is slow. So what we did was we decided that we would make it really clear to staff what medications they should be wearing gloves for. So we said you don't need to wear gloves when you're doing solid administration. We'll know that you can administer tablets and things without touching the tablets. But they would need to risk assess and wear gloves for any medication where they were in contact with a bodily fluid. So we were quite clear about eye drops, nose drops, any therapeutically active cream they would be wearing gloves for. Non-sterile gloves, obviously, and if they were dealing with liquid hormones or cytotoxic medications. One of the common questions we get is, did we list them and provide them lists for each ward? We did not provide them with a list for every ward. And the reason is that by the time we go into trade names, other names, as a registered nurse or professional giving a drug, you should be aware of the drug you're giving and the properties it has. So we encouraged our staff that actually this is their risk assessment to make. They should know what medications they're giving. We're giving them the information, and it's for them to move forward and make the risk assessment. And then we went further, because about 70 to 80% of the children realistically have central lines at GOSH. So they would make their risk assessment about the medication they were giving. They would then decide or make a risk assessment as to whether they were drawing back from a central line. If they were going to draw back and disconnect, we advised them to wear gloves. If they were drawing back just to check the line was patent, we advised them, if they were confident in doing that and knew the child wouldn't move, then they didn't need to wear gloves and they could continue on. When we presented it to a group of all the different people that give IV medications in the trust, so renal, TPN, there were about 40 people in the room, I think. And they went as far as saying, well, actually, surely if it's a child that's got a long-term central line and it's dry and intact, surely we don't need to wear gloves for the dressing change either. So they even challenged us further, which was good. And they said, 20 years ago, we didn't wear gloves for that. So it was quite interesting as we discussed it with people. And then we decided that, as well as doing it, we wanted to have some kind of idea of how well we'd done it. So we knew we had the hand hygiene audits, which we've continued with. We now do quarterly hand hygiene audits where we specifically look at IV administration and if we're following our gloves off guidance or safe in our hands guidance. We collect infection rates for virology, hospital-acquired viral, gastric, respiratory infections, etc. So we continue collecting those. Soap and hand sanitizer usage should be the simplest thing to collect, because we were interested if our hand sanitizer usage would go up. But it's actually been the most complicated, primarily because our cleaning is outsourced and they order the sanitizer. We do have data on glove and apron usage, which I'll show you in a minute, and we've got our dermatitis levels in staff. And then we have started to collect qualitative data from patients and families. I've got some financial and environmental data to show you as well. So this goes back a fair way, but it does give you an idea of how many skin assessments are seen in occupational health. The process isn't perfect, I will be honest, as in probably most organisations, but you can see in about February, March, May 18, we sort of had a peak. So just before we began, we were seeing sort of peaks and troughs. So we did collect data. I haven't got a pointer to show you. We did collect data from the supply chain about our non-sterile glove ordering. You can see a massive peak in about October 17. That's to do with the opening of a new clinical building, so about 10 new wards open. So that's bulk buying for those buildings. But you can see in April 18, where we launched a campaign, that really immediately we saw a reduction. There are spikes. The spike in July is related to an outbreak we had of norovirus. And obviously, over the winter, we expect to see more children in contact precautions with acute respiratory or gastric infections, which we think accounts for the rise there. We're just waiting till the end of February to update the rest of the data. And we see similar in aprons. So we also, as a result of this, have managed to reduce our apron usage. And one thing we also did, which I haven't really mentioned, but it's important in terms of the environmental, is we changed from, in the ANTT preparation, from using bungs, which had always been used routinely for the end of syringes at Great Ormond Street, to giving staff the option to put it back in the packet. So we changed that, and you can see the massive impact there. They still use bungs in some if they've got lots and lots of IV administration. They want to be really clear about how it's laid out. If it's just a single dose, then they'll use the packet now. And then we also were able to collect the costs. So I'll show you the costs amalgamated in a minute. There has been a slight rise, but I think the cost of gloves has increased with the price of oil, someone told me. So, and the same with aprons. But it's quite unusual to see in an SPC chart an immediate reduction like that. So we launched a campaign we trained in April, and we launched a campaign right at the end of April, the beginning of May. So almost from go live for people, there was an immediate reduction that's pretty much been sustained. We will expect some variation over season, obviously. So I was asked to present at a sustainability workshop just before Christmas, and it's my most tweeted tweet. Well, I worked this out. But anyway, so I worked out how much a bung weighed, how much an apron weighed, how much a pair of gloves weighed, and then how much they cost, obviously, and then worked out what the environmental impact of what we'd done just based on our data was so far. And it was quite astonishing, actually, in terms of cost. So this is up to the end of November 2018, but this has only began in April. So when you look at the amount of plastic, if you think a large horse weighs 1,000 kilograms, that's just one organisation with 380 beds. It really is astounding, the amount of plastic that we use. So we felt this was really important, and when we feed back next year, this is what we're going to go through with our staff. And the financial costs alone now, it's been picked up as not a quality improvement project, but as a trust project to save money. It's not the reason we did it, but it's been picked up now because the cost savings have been so substantial. So it's a really quick overview. I can't go into all of exactly how we did it, but the things that we want to do are obviously carry on measuring our glove usage. For us, it's been really important, and I think it's really useful to demonstrate to people what we've been able to show. We continue to see how gloves are being used in hand hygiene audits, and for the most part, people are on board. One staff member who came and did the audit said that before we actually changed the guidance nearly a year ago now, it's gone. Before we changed the guidance nearly a year ago, her hands were so bad that she was almost taken out of clinical practice. Now her hands, from a result of not wearing gloves so much, are improved massively. So we're about to make her a case study and sort of demonstrate across the trust the changes that have been made to people. We've done the further training now of the other staff, the cleaners, the porters. It continues on because it's a never-ending process because people roll and change. And we've started collecting information from patients and families really about the effect it's had on them. The day that we launched, somebody walked up to us in the lagoon, which is the equivalent of our canteen, and said, "Oh, you're not wearing gloves for things you used to today?" And we said, "Well, no," and we explained what had gone on. She said, "Well, it was actually really reassuring," she said, "because a year ago my other child had the same procedure done, and they wore gloves when they gave the medication. Today they didn't wear gloves, and I saw someone clean their hands." She said, "I'm sure they cleaned their hands a year ago, but actually visually seeing that changed how I thought what I perceived was being done." So quite important. There's some other work going on as well. So we've, GOSH submitted to the showcase for NHS England. So our case study's on there, and Amy can be contacted if you want any further information. We've doing a step-by-step guide as to how we did our glove awareness programme, which will be launched with the RCN Glove Awareness campaign for 2019, if anybody's interested. And the final thing just to say is there's some work going on at the moment by the RCN around aseptic technique, really looking at when we do need to wear gloves and what aseptic technique is, which feeds quite nicely into this work. And they've got a symposium in April, if anyone's interested. So I believe that's me. Thank you.